The anterior hip replacement is begun with an incision over the anterior aspect of the affected hip. After the incision, the fascia is identified and the sartorius and the tensor muscle is used, and an incision is made between them to gain access to the hip capsule. This is a natural plane, and no nerves or muscles are disturbed. The hip capsule is then excised, and this reveals the arthritic hip joint. Bone spurs or osteophytes are then removed. Following this, the hip is then dislocated to help loosen the soft tissues for later preparation. This is done with a corkscrew in the femoral head. After dislocation, the hip is then reduced back into the joint in its normal position. A saw is then used to remove the arthritic femoral head. After it is removed, the hip socket is revealed, and the acetabulum is prepared with a reamer, followed by placement of the acetabular component. X-ray is used at this time to confirm perfect placement of the component. This is followed by placement of a polyethylene liner. Once the liner is put in position, attention is turned to the femur. It is externally rotated to gain access to the femoral canal. Different broaches and stems are used to determine the right size that fits within the femoral canal. A trial is then done with a trial neck and head. The hip is then reduced back into the socket. At this time, X-ray is used to confirm placement of all implants. It is also used to make final adjustments to the length. X-ray compares the length of the opposite extremity so that we can make sure that the extremity lengths are symmetric. Once that has been determined, the hip is then dislocated one last time and the trial implants removed. This is followed by placement of the final implants with a final ceramic head. This is then reduced into the hip joint and X-ray is used one last time to confirm placement of all final implants. The fascia is then closed, followed by closure of the skin with an absorbable subcuticular stitch. The